We are live now.
Good evening, everyone. I'm Monica, medical advisor. I welcome you all instead of Shield Healthcare and my dear speaker. And today's topic is regarding PCOS holistic approach by Dr. Surekha Vinay, MBBS, DGO, DNB, OBG, consultant OBG and infertility specialist and laparoscopic surgeon from Gypsum Clinic, Karnool, Andhra Pradesh. I welcome you, ma'am. And before going to the webinar, I wanted to give a brief introduction regarding our Shield Connect page. Shield Connect page is basically a knowledge, information, and knowledge sharing platform which connects all the doctors throughout the India, and we have information related the upcoming webinars and webinars which have been completed, and various blogs related to gynecology, and our leaders are the doctors from overall India, and we have different newsletters related to OBG and gynecology. We have several awareness programs. So please do once visit our page for medical information regarding OBG and gynae. I hand over to you. I hand over session to you, ma'am.
Thank you. Today we are going to discuss about PCOS, holistic approach. As we all know, this is a disease from womb to tomb. So no one is exempted. Let us know in a holistic approach, PCOS. The outlines, let us see background, definition and prevalence, issues related to PCOS and approach to management. Coming to the background, it started in 1935 when Steen IF and Leventhal ML designated PCO as a syndrome. And in 80s and 90s, there was addition of ultrasound criteria. And in 2013, Rotterdam Consensus Conference was started, and 2018 international evidence-based guideline for the assessment and management of polycystic ovarian syndrome was released. Coming to the introduction, PCOS is not merely a reproductive disorder, but an endocrinological disorder affecting women in their reproductive years. Although hyperandrogenism and infertility that PCOS causes are distressing to young women, its metabolic sequelae eventually plague the individual in terms of morbidity and mortality. Polycystic ovary. A polycystic ovary is defined as an ovary containing 12 or more follicles or 25 or more follicles using new ultrasound technology, that is high resolution scanning, measuring 2 to 9 mm in diameter, or an ovary that has a volume of greater than 10 ml on ultrasonography, a single ovary meeting either or both the criteria. Ultrasound should not be used for the diagnosis of PCOS in those with a gynecological age of less than 8 years, that is within 8 years after menarche is attained, due to the high incidence of multifollicular ovaries in this life stage. Coming to the clinical features, if you see the features, mainly 3 are interlocked or intertwined. One is gynecological, irregular menses and infertility; metabolic, that is insulin resistance, obesity, increased chances of type 2 diabetes mellitus, acanthosis nigrans; and the third manifestation of androgenic features, alopecia, hirsutism, and acne. Criteria for diagnosis of PCOS. Criteria 3 are taken, that is high clinical hyperandrogenism or biochemical hyperandrogenism. And the second one is oligoanovulation and polycystic appearance of ovaries. If you look into the Rotterdam criteria, only 2 out of 3 are necessary. And if you look into the NIH, hyperandrogenism and oligoanovulation should be present, but polycystic appearance of ovaries may be present or may not be present. Coming to the androgen excess society, hyperandrogenism is the most important feature along with one of the two remaining criteria, that is oligoanovulation and polycystic appearance of ovaries. Phenotypes of PCOS. In 1990, it was A and B phenotypes, and in 2006, it came into phenotype A, B, and C. And 2003 Rotterdam criteria, they were divided into 4 phenotypes: hyperandrogenism and hirsutism, ovulatory dysfunction, and polycystic ovarian morphology. In phenotype A, all the 3 are present. In phenotype B, only first 2, that is hyperandrogenism and ovulatory dysfunction, is present. There is no polycystic ovarian morphology. In phenotype C, hyperandrogenism and ovarian morphology is present, but there is no ovulatory dysfunction. Coming to the phenotype D, hyperandrogenism is absent, but ovulatory dysfunction and polycystic ovarian morphology both are present. Factors contributing to PCOS phenotype. If you look into the PCOS phenotype, it starts from in utero, that is CNS programming, epigenetic changes, genetic variants. And once the child has attained adrenarche, there are inflammatory factors. In adolescence, environmental exposures, exercise and activity, and hormonal exposure is there. Coming into adulthood, ovarian factors, androgen excess, adrenal factors, and ectopic fat storage is there. And in pregnancy, there is insulin sensitivity and insulin secretion, along with neuroendocrine factors and diet. PCOS pathophysiology. In PCOS, if you look into the hypothalamus, is triggered by altered sex steroid levels, which in turn causes abnormal GnRH secretion from the pituitary, leading to increased LH and decreased FSH, which acts on the liver and causes decrease in SHBG, and IGF-BP also decreased, in turn which is influenced by the insulin resistance. Insulin resistance is circulating insulin is increased, bioavailable E2 is increased, bioavailable testosterone is increased, and bioavailable IGF-1 is increased. These act on the ovary, causing a decrease in FSH and interaction between IGFs and insulin, which in turn is acted upon by the increased LH from the pituitary, and they all act causing release of testosterone, leading to increased androgens, in turn through 5-alpha reductase, dihydrotestosterone, and at the level of the skin, that is adipose tissue, peripheral and target tissues, the E2 is increased, and which these androgens act on the adrenals, which in turn releases DHEAS in a large amount. Coming to the development of insulin resistance, the one and only important pathology. If you see into the number 1, that is insulin has a control on LH levels. Insulin is primarily responsible for contributing LH. So it is directly proportional. And coming to 2, it controls androgen levels. Insulin mediates androgen production in the theca cells. And the third part is insulin resistance coexists in PCOD. Women with PCOS have decreased sensitivity to circulating insulin, irrespective of weight, that is obesity, thus suggesting that this insulin sensitivity is intrinsic to PCOS. And the fourth factor, inositol deficiency, drives PCOD. This insulin resistance seems to be driven by deficiency of myoinositol and D-thyroinositol. And insulin signaling is damaged in PCOD. Myoinositol deficiency triggers disordered insulin signaling, And the last feature is insulin leads to hormonal and metabolic defects. That is, insulin dysfunctioning disrupts LH-FSH pathways and hyperandrogenism. Complications of PCOS. One of the complications is infertility. Primary infertility was reported in 50% of women, and secondary infertility was reported in 25% of women. Coming to the obstetric complications, 3 times higher risk of preeclampsia, 3 times higher risk of GDM, 2-fold increase in preterm deliveries, and 2-fold increase in the risk of IUGR. Cardiovascular complications, there is 2-fold increase in the risk of MI, 2-fold increased risk of hypertension, and metabolic disturbances, 5 to 10-fold increase in risk of developing type 2 diabetes mellitus, and oncologic increased risk of endometrial cancer, and psychological 4-fold greater odds of depressive symptoms, high prevalence of anxiety disorders, and reduced quality of life. Long-term issues associated with PCOS. Coming to the genetics and lifestyle factors, both affect the hormonal changes, and obesity exacerbates hormonal changes. In turn, they lead to increased androgens and increased insulin. They are interconvertible. One is leads to other. And the increased androgens manifest as hirsutism and acne. Along with that, increased androgens act on ovarian follicles, causing anovulation and increased estrogen, leading to menstrual disturbances and subfertility, and increased insulin along with action on ovarian follicles causing anovulation and increased estrogen. It also causes diabetes, metabolic syndrome, which in turn leads to cardiovascular risk, and the psychological issues of body image, self-esteem, depression, anxiety. These are all long-term effects associated with PCOS. The metabolic syndrome and PCOS. The prevalence of metabolic syndrome in women with PCOS is approximately 43 to 46% according to WHO. Type 2 diabetes mellitus or impaired fasting insulin or impaired glucose tolerance or insulin resistance plus 2 of the following features, that is BMI more than 30 kgs per meter square, HDL less than 1, that is less than 40 mg per deciliter, triglycerides more than 1.7, that is 150 milligrams per deciliter, and blood pressure more than 140 by 90 mm of mercury or use of blood pressure medication, microalbuminuria, that is more than 20 picograms per liter per minute, and albumin creatinine ratio is more than 30 milligrams per gram. Insulin resistance is a major underlying pathophysiologic abnormality linking the metabolic syndrome and PCOS. Weight loss with lifestyle modification is the safest and cheapest therapy that has shown benefit both in metabolic syndrome and PCOS. PCOS and cardiovascular disease, premature association. Women with polycystic ovarian syndrome are at increased risk for cardiovascular disease given the high prevalence of the metabolic syndrome X. Stronger evidence between an increased risk of cardiovascular events in women with menstrual irregularity. The existing data suggests that PCOS adversely affect or accelerate the development of an adverse cardiovascular risk profile and atherosclerosis. Body image and quality of life in PCOS patients. PCOS disease-specific questionnaire known as a PCOSQ has been developed to study the psychopathology of women. Obesity and infertility cause the greatest degree of stress. Both anorexia nervosa and bulimia have been linked with PCOS. Many conditions coexist with PCOS such as pelvic pain, depression, and altered mood. Cardiovascular risk in PCOS. Several studies using intima media thickness as a surrogate for cardiovascular risk evaluation have shown potential increased cardiovascular risk in women with PCOS. Coronary artery calcification and PCOS. A similar study using coronary artery calcification as risk stratification has shown increased risk in patients with PCOS, sleep apnea, and other sleep disorders. Multiple groups have documented an increased risk for sleep apnea and other sleep disorders, including increased daytime somnolence, such as sleep disordered breathing in women with PCOS. Polycystic ovarian syndrome and cancers. The prevalence of endometrial hyperplasia with and without atypia in women with PCOS varies from 1 to 48.8%. Chronic anovulation, which results in continuous estrogen stimulation of the endometrium, unopposed by progesterone. Obesity, hyperinsulinemia, and hyperandrogenism state in PCOS results in increased bioavailability of unopposed estrogens by progesterone due to the increased peripheral conversion of endogenous androgen into estrogen. Women with PCOS has a 2.5-fold increased risk of developing ovarian cancer. Clomiphene citrate and gonadotropin therapy or ovulation induction was found to increase the relative risk of ovarian tumors in women with PCOS. Ovarian cancer and breast cancer. Women with PCOS had a 2.5-fold increased risk of developing ovarian cancer. Clomiphene citrate and gonadotropin therapy or ovulation induction was found to increase the relative risk of ovarian tumors in women with PCOS. Meta-analysis about the association between PCOS and breast cancer showed that the risk of breast cancer was not significantly increased overall. However, some studies showed that women with PCOS, independently of age at menarche or menopause, parity, using oral contraceptive pill, BMI, and family history of breast cancer, have 1.8 times as likely to report benign breast disease. PCOS and pregnancy. Multiple pregnancies are the most important cause of the increased perinatal morbidity observed following fertility treatments. Miscarriage. It is still debated whether women with PCOS have an increased risk of marriage, pregnancy-induced hypertension, and preeclampsia, which is 3 to 4-fold increased risk. PCOS and GDM affects 4 to 7% of pregnancies overall. There are 2.4-fold increased risks of GDM among PCOS women, independent of age, race, and ethnicity, and multiple gestations. GDM complicates 40 to 50% of PCOS pregnancies. PCOS and hypertensive disorders in pregnancy. Hypertensive disorders occur in 8% of PCOS pregnancies. Increased levels of androgens in PCOS have been associated with the development of preeclampsia. Coming to PCOS and COVID-19. Factors increasing the risk of severe COVID-19. One is obesity, hypertension, type 2 diabetes, metabolic syndrome, ethnic minority group, high cytokine levels, high androgen levels, low vitamin D levels. These factors increasing the cardiometabolic risk in PCOS. Treatment aim to restore natural spontaneous menstrual cycles, reduce androgen level, overcome insulin resistance, improve oocyte maturation and oocyte quality. Coming to management, the first line of treatment is lifestyle modifications. Improvement in lifestyle. In obese patients, weight loss, changes in diet and physical activity recommended. Weight loss decreases serum insulin, androgen levels, reduces the risk of glucose intolerance and type 2 diabetes mellitus. Pharmacological interventions. In the presence of insulin resistance, glucose intolerance, or dyslipidemia that persist after lifestyle modifications. Managing menstrual disturbances. If the patient does not wish to conceive, medical therapy is directed towards interruption of the effect of unopposed estrogen on the endometrium. Non-fluctuating levels of unopposed estradiol in the absence of progesterone causes irregular uterine bleeding, amenorrhea, infertility, and increased risk of endometrial cancer. OCPs elevate risks of cardiovascular disease. They cause dyslipidemia and increase chances of thromboembolic events. There are evidences suggesting increased risk of type 2 diabetes with OCP usage, and this effect can be dose dependent. Coming to managing hirsutism, spironolactone, weak evidence. Dose is 25 to 100 milligrams twice a day and is titrated to balance efficacy while avoiding side effects such as orthostatic hypotension. A full clinical effect may take 6 months or more. It can cause and exacerbate hyperkalemia. Spironolactone should be used cautiously in women with renal impairment. Rarely, exposure has resulted in ambiguous genitalia in male infants. Cyproterone acetate. This is a progestogen with anti-androgen properties. It is frequently combined in an oral contraceptive tablets and is popular in the treatment of PCOS. When given as 100 milligrams per day, it inhibits testosterone production, resulting in up to 75% decrease in circulating testosterone levels. Flutamide. It is an androgen receptor antagonist and is another non-steroidal anti-androgen. The most common side effect is dry skin, but its use has been associated with hepatitis in rare cases. The common dosage is 250 milligrams per day. The risk of teratogenicity with this compound is significant and contraception should be used. Finasteride, inhibitor of type 2 5-alpha reductase enzyme found in the hair follicles on the top of the scalp and in the sebaceous gland ducts. Better tolerated than other anti-androgens with minimal hepatic and renal toxicity. However, it has well-documented risk for teratogenicity and feminizing in a male fetuses. Ornithine decarboxylase inhibitors. Ornithine decarboxylase is necessary to produce polyamines, and inhibition of this enzyme limits cell division and function in the pilosebaceous unit. Eflornithine has been found to be effective as a facial cream for the treatment of unwanted facial hair. It is pregnancy category C drug. It appears to be well tolerated with only about 2% of patients developing skin irritation or other adverse reactions. Relapse is common after stopping. Studies suggest myoinositol at 4 grams per day dose in powder formulation can tackle hirsutism without any side effects. Treating anovulatory infertility. Medical, it is ovulation induction and surgical ovarian drilling. Let us see ovulation induction. The recommended first-line treatment for ovulation induction remains the anti-estrogen clomiphene citrate. Recommended second-line intervention is exogenous gonadotropins. Letrozole may also be tried, but evidences are limited. Strong evidences confirm efficacy of inositols in restoring fertility in PCOD patients. Coming to the surgical ovarian drilling, this is primarily recommended as second-line infertility therapy. Multiple pregnancy rates are reduced in those women who conceive following laparoscopic drilling. In some cases, the fertility benefits of ovarian drilling may be temporary, and adjuvant therapy after drilling with clomiphene may be necessary. Ovarian drilling does not appear to improve metabolic abnormalities in women with PCOD. Coming to ovulation induction, clomiphene citrate. Starting on day 2, 3, 4 or 5 makes no difference. Dose is 50 milligrams per day, raising by 50 milligrams if no ovulation, even without withdrawal bleeding. When to stop? When 6 ovulatory cycles fail to yield a pregnancy, when no ovulation with 150 milligrams per day, and if endometrial thickness less than 7 mm at ovulation. Aromatase inhibitors, theoretical advantages. Letrozole, that is 2.5 mg tablet. They do not block estrogen receptors. They have no detrimental effect on endometrium or cervical mucus. Negative feedback mechanism not turned off. Less chance of multiple follicular development. Anastrozole. Anastrozole 1 milligram per day versus clomiphene 100 milligrams per day. Anastrozole produces fewer follicles, thicker endometrium. May be used successfully for ovulation induction. Anastrozole 1 mg versus letrozole 2.5 mg. Letrozole superior in ovulation and pregnancy rates. Metformin. Metformin recommended in the presence of metabolic features, that is BMI more than 25. It is an insulin sensitizing agent. It is increased but low ovulation frequency, lower conception rate for ovulation than all other methods. If BMI is more than 30, consider metformin in combination with clomiphene citrate. May improve response rate to clomiphene citrate, and there is a debatable reduction in androgenic symptoms. Recommended in the presence of metabolic features, that is BMI more than 25. It is an insulin sensitizing agent, increased but low ovulation frequency, lower conception rate for ovulation than all other methods. No satisfactory treatment, that is insulin sensitizers metformin. The good about them is the lower hyperinsulinemia, aid weight loss. And coming to the bad feature, insulin resistance is not seen with all patients with PCOS. Coming to the oral pills, the good is they might aid in regularizing menstrual cycles. Clinical evidences do not support this. It aids combating hyperandrogenism, and the bad feature is they does not restore ovulation. We are treating symptoms. We are treating symptoms are not the cause. Coming to the hormonal imbalance, and other thing is metabolic imbalance. In hormonal imbalance, there is hyperandrogenism, LH-FSH imbalance, and in metabolic imbalance, there is insulin resistance and dyslipidemia. Both of them combinedly lead to oligoamenorrhea, anovulation, acne, hirsutism, virilization, acanthosis nigrans, impaired glucose tolerance, and obesity. And insulin sensitizers which are used are metformin and pioglitazone. And anti-androgens, spironolactone, cyproterone acetate, flutamide, and finasteride. And coming to the OCPs, they are also used. Ovulation inducers, that is clomiphene citrate, letrozole, and anastrozole. And coming to the cosmetic treatment, laser hair removal, bariatric surgery, acne therapy. And coming to the others, it is laparoscopic ovarian drilling and statins. Root cause of developing PCOS in women is due to the reduced or altered level of myoinositol in the ovary. If you look into the obesity and metabolic syndrome, there is insulin resistance, which in turn leads to reduction of hepatic SHBG release, and the metabolic syndrome, the GnRH pulses, LH increase, FSH deficiency, and melatonin downregulation, which leads to increased androgen production from the ovary and adrenals, and which leads to hyperandrogenemia. Here there is myoinositol and D-chiroinositol. They act on insulin resistance. If you look into infertility and menstrual abnormalities and polycystic ovaries, there is LH, FSH imbalance, reduced aromatase activity, and the glucose uptake is reduced, which in turn leads to the myoinositol, which is present in the ovary. It has effects on FSH, it has effects on insulin, it has effects on the ovary cell, which decreases insulin sensitivity. Current treatment paradigms. Coming to metformin, pros regarding attacks insulin resistance and wide experience, and the cons: does not prevent TDM, cannot manage severe cases, not tolerated by all, crosses placental barrier, fetal risks unknown. It is a category B drug by US FDA. And coming to 2015, insulin is treated and it has pros of its high efficacy, but the cons are it is an injectable, hypoglycemia and weight gain side effects, large for gestational age babies, unable to prevent fetal complications of GDM, does not tackle the root cause. In 2017, the inositols were introduced for the treatment, and the benefits are it both prevents and manages GDM, attacks the root cause of GDM, leads to favorable fetal and maternal outcomes, shown to be superior to metformin, safer than both insulin and metformin. Could inositols be considered to treat PCOD? Now, this is a big question. Yes, the answer is yes. Myoinositol and inositols. These are commonly found in fruits. Grapefruit the highest, vegetables, leafy vegetables the lowest, and in all foods containing seeds like beans, almonds, and walnuts, the highest concentrations of inositols. Myoinositol. Myoinositol plays an important role as secondary messenger in human body in multiple functions. Cellular response needs myoinositol. Myoinositol is present in high concentration in ovarian follicular fluid. Myoinositol is essential for normal reproductive function of female. High levels of myoinositol in follicular fluid is very important for follicular growth and oocyte maturation. High levels of myoinositol ensure quality oocyte. Mechanism of action of myoinositol: corrects altered LH-FSH ratio by regulating GnRH pulsatility, improves insulin sensitivity by acting as a secondary messenger for insulin action in peripheral tissues, brings down plasma levels of insulin, improves ovulation and oocyte quality by acting as a secondary messenger for FSH. Benefit of myoinositol: 2 grams twice daily. Restores cycle faster. 88% patients restored spontaneous menstrual cycle during treatment. 72% maintained normal ovulatory activity during the follow-up period. More than 30% of the patients established normal ovarian rhythm through the 16-week treatment period. This is an article regarding Gynecological Endocrinology 2007. Myoinositol and hyperandrogenism. 73% reduction in free testosterone levels, 92% increase in SHBG, that is sex hormone binding globulin. If you look into the picture, the orange color represents free testosterone, that is, it is 1 to 2% active. And the blue goes with testosterone plus albumin, 20 to 40% mildly active, and the green testosterone plus SHBG, 60 to 80% inactive. So the SHBG level is increased with myoinositols. Coming to clinical evidences for myoinositol. This is a published paper in 2014. If you look into the census from 2000 to 2014, a lot of studies are done, around more than 39,000 patients were studied. This is a PubMed research. Endocrine and clinical effects of myo-inositol administration in polycystic ovarian syndrome. That is a randomized study. 50 overweight PCOS patients were divided into two groups. One group, Group A, given myo 2 grams per day, and Group B only folic acid 200 milligrams as placebo, and the duration was for 12 weeks. Myo-inositol decreases both insulin and BMI. No changes were seen in patients treated with folic acid. This is a study in 2013. You can see the difference with the treatment of myo-inositol. After 12 weeks of myo administration, insulin sensitivity and HOMA index is significantly improved. HOMA reduction, that is around 56% HOMA reduction was there after 12 weeks of treatment. HOMA-IR, that is homeostasis model assessment, is used to predict the relationship between beta cell deficiency and insulin resistance. HOMA-IR is equal to glucose into insulin by 405. Normal HOMA-IR is less than 3. HOMA-IR more than 2.5 is considered a reasonable indicator of insulin resistance. This is done in 2011 Journal of Diabetic Investigations. Coming to the myo-inositol administration positively affects hyperinsulinemia and hormonal parameters in overweight patients with polycystic ovary syndrome. This is a study in March 2008, and there the inference was insulin sensitivity expressed a glucose to insulin ratio and HOMA index resulted significantly improved after 12 weeks of treatment with myo-inositol, and the menstrual cyclicity was restored in all menoric and oligomenoric patients. Coming to metabolic and hormonal effects of myo-inositol in women with polycystic ovary syndrome, this is a double-blind trial, and myo-inositol was given. The area, if you look into the graph, the area under the plasma insulin curve after oral administration of myo-inositol gives 65% reduction in testosterone levels, and 69 patients ovulated with myo-inositol acid. So there is a gross improvement in the levels of testosterone and ovulation rates. 40% of patients with myo-inositol and 90% of pregnancies with fetal heart. This was a study, and only 2 pregnancies resulted in spontaneous abortion. And this is according to a gynecological endocrinological research paper in 2007. Myo-inositol offers best clinical pregnancy rate and delivery rate as compared to placebo. This is a paper presented in 2013 regarding myo-inositol and placebo. Definitely there is a good percentage of clinical pregnancy rate and delivery rate when myo-inositols were prescribed. Myo-inositol shows a significant improvement in metabolic characteristics. The myo group and placebo group. The characteristics which were taken were systolic blood pressure, diastolic blood pressure, triglycerides, and total cholesterol. If you look into the myo group, baseline systolic blood pressure 131, after treatment it was down by 127, and the diastolic blood pressure 88 came down to 82, triglycerides 195, they came down after treatment to 95, and the total cholesterol 210 came down to 171. If you look into the placebo group, the baseline 128, after treatment it was actually a little bit high. Both diastolic blood pressure also 86 came to 90, and triglycerides there was 166 to drop in 148, and total cholesterol 195 to 204. The p-value was very significant when compared to myo-inositol group and placebo group. Myo-inositol in patients with polycystic ovarian syndrome, a novel method for ovulation induction. This was a paper presented in 2007. The conclusion is myo-inositol is a simple and safe treatment that is capable of restoring spontaneous ovarian activity and consequently fertility in most patients with PCOS. This therapy did not cause multiple pregnancy. Coming to the other paper presentation 2015, this is from Gynecologic Endocrinology. Ovulation induction with myo-inositol alone and in combination with clomiphene citrate in PCOS patients with insulin resistance. So they made a study of 47 anovulatory PCOS women with myo-inositol. 29 ovulated, 11 became pregnant, and 18 non-pregnant, and 18 members were resistant to inositol treatment. Coming to the distribution of women according to BMI, all were normal and 12 were overweight and 20 were obese. And the features they took: ovulating with myo and pregnant with myo, non-pregnant with myo, and resistant. So the inference is myo-inositol treatment ameliorates insulin resistance and body weight and improves ovarian activity in PCOS patients. This is a research article in 2016. Myo-inositol as a safe and alternative approach in the treatment of infertile PCOS women. It is a German observational study. The conclusion was myo-inositol is not only an effective alternative in the treatment of PCOS patients, but also a secure one, as no side effects could be observed in the standard dosages. This is an International Journal of Endocrinology. Coming to one more research paper in 2007, N-acetylcysteine and clomiphene citrate for induction of ovulation in PCOS syndrome, a crossover trial was done, and the outcome in clomiphene citrate group and N-acetylcysteine group, there was a much significant difference. Consensus algorithm for ovulation induction in PCOS. If you look into the PCOS with Rotterdam criteria, if ovulation is detected, you can await natural conception. And if there is no ovulation, they need full fertility investigations, assessment of insulin resistance, if overweight, lifestyle plus bariatric surgery. And with this treatment, ovulation is detected and you can avoid natural pregnancy. If no pregnancy after 6 to 9 cycles, it is better to go for IVF. And if ovulation is detected, proceed to ovulation induction if BMI is satisfactory. And coming to clomiphene citrate or letrozole, if ovulation is detected, if there is no result, no pregnancy in 6 to 9 cycles, IVF is the best option. Coming to gonadotropins or clomiphene citrate plus metformin or laparoscopic ovarian drilling, if ovulation is detected, yes or no, the patient is pregnant. If the patient is not pregnant for 6 cycles after gonadotropin therapy or combination medical therapy, you need to go for IVF. IVF, that is GnRH antagonistic protocol, if after detection of ovulation there is no pregnancy. Effects of inositol in IVF cycles. Results and conclusion. This was a study done in 2010. At the end of the treatment, the number of follicles of diameter more than 15 mm visible at ultrasound during stimulation and the number of oocytes recovered at the time of pickups were found to be significantly greater in the group treated with myo-inositol so as the average number of embryos transferred and embryo grade 1. Significantly reduced was the average number of immature oocytes, that is vesicles, germ, and degenerated oocytes too. So minoxidil was used in IVF cycles. There was difference in the quality of the oocytes. Myoinositol improves oocyte quality and maturation. Myoinositol plays a key role in nuclear and cytoplasmic oocyte development. Higher concentration of myoinositol in follicular fluid is a marker of good quality oocytes. This is a research paper from 2012's Gynecological Endocrinology Research. In IVF programs, myoinositols improve both the quality and the number of mature oocytes. There is significant reduction in the number of immature oocytes. It reduces recombinant FSH dosage by 400 international units. It also reduces the chances of OHSs, and it reduces the number of wasted IVF cycles. All these were studies done on myoinositols in IVF programs. International Society says, that is according to Escher 2008, myoinositol can be evaluated as the primary method of ovulation induction in PCOS women. In 2012, American Society of Reproductive Medicine, it gave this inference, that is myoinositol treatment should be routinely introduced in IVF protocols. That is ASRM 2012. Coming to the side effects of myoinositols, myosupplementation is well tolerated and safe both in obese and lean PCOD patients. And side effects when present are very mild and mainly gastrointestinal, that is nausea, flatus, and diarrhea. Not only safe in pregnancy but beneficial. It reduces chances of neural tube defects and improvement in the gestational diabetes. This paper was published in 2012. 84 gestational diabetes patients, 24, this is a study done on DDM patients, there were 84. 24 received myo plus folic acid and 45 received only folic acid 400 micrograms per day. And the duration of treatment was 8 weeks. Myoinositol supplementation is a simple and safe step in the treatment of gestational diabetes. And this was a paper published in Diabetic Medical Journal in 2011. And coming to the myoinositol, takes total care of symptoms. If you see the chart, myoinositol is in the center. It is acting on improving insulin sensitivity. It decreases insulin resistance levels. It improves glucose utilization. It improves pregnancy rate. It restores menstruation and normal ovulation. And it also reduces free testosterone. It acts on metabolic and hormonal imbalance in PCOS. Now the take-home message is, the comprehensive management of PCOS requires a patient-centered approach with a detailed history, significant time dedicated to thorough education and counseling about the disorder, remaining up to date on newest advances in the literature, improvement in health of the PCOS women in pregnancy could help prevent disease in the next generation. If obese, weight loss should be recommended prior to initiation of therapy. Hyperandrogenism, hyperinsulinemia should be looked for in every PCOS woman. Ovulation-inducing agents and adjuvants should be customized. PCOS patient is the most difficult to treat with IVF. Cycle cancellation rates and risk of OHSS are higher. Fine tailoring of ovarian stimulation is necessary to avoid complications. And treating physician should be aware of the difficulties and remedies and solutions. If you look into the chart PCOS, we need to prepare and assist women with the necessary information and resources needed to get tested, communicate information to the public and to women diagnosed with PCOS, that is C. And coming to O, we need to overcome to assist women diagnosed with PCOS to overcome their symptoms and lessen related health risks, and to support them, provide a support network to freely and openly discuss all aspects of PCOS. Thank you.
Thank you, ma'am. Thank you so much for your good explanation regarding PCOS and its management. It was really a wonderful session. And ma'am, actually we had few questions
Okay.
from the delegates. So I want to repeat that question. One question is, patient has hyperandrogenism symptoms,
Okay.
but patient doesn't have polycystic ovarian in ultrasound. Neither patient have irregular periods, but patient have only hyperandrogenism symptoms. So how do we treat that condition?
First of all, we should evaluate whether it is a clinical hyperandrogenism or biochemical. We need to go for the testosterone levels, because hyperandrogenism is one of the most important feature of PCOS, that is metabolic disturbance. So we need to look for symptoms and age of the patient. If she is an adolescent or it's within 8 years of menarche, we need to give them some time and follow up. And then need counseling regarding menstrual abnormalities along with the hyperandrogenic features. All patients, they do not need immediate treatment. Hello?
Ma'am, another question.
Yeah.
Another question is, how effective are these lifestyle modification would help PCOS patient?
Lifestyle modification is the one and only treatment we need to tell each and everyone, with or without PCOS. But with PCOS, the first and foremost thing is we need to take a detailed history of their lifestyle and counsel them and tell them the future if they continue the same lifestyle which is associated with their PCOS pathology.
Yes, ma'am. Ma'am, currently we have only two questions which will you answer. And thank you so much, ma'am, for answering these questions, for explaining the slides, and that I feel most of the delegates would be beneficial because of this information. And even I got a few new things regarding this. Thank you, ma'am. Thank you so much. Uh, shall we end the session now, ma'am?
Yeah. If there are any questions, they can mail me.
Yeah, I will mail.
Thank you so much, Monica.
Thank you.
Thank you.